This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
You are listening to the Laerdal podcast, and my name is Michael Sauter. I'm the Chief Learning Officer at Laerdal, and I have a particular soft spot for impactful education and healthcare quality improvement. My co-host today is my good colleague Bjørn Egeland. On the podcast today, we are joined by Dr. Victoria Brazel from Australia. Welcome, Victoria.
Oh, it's lovely to be here, Michael, and congratulations on your podcast.
Thank you very much. Kind of you to say so. So for those who do not know Victoria, she's from Australia. She's a practicing emergency physician at the Gold Coast University Hospital. She's a professor of emergency medicine at the Bond University and also faculty at the Harvard Massey Institute. She's the medical director of the Gold Coast Simulation Service, part of the Bond Translational Simulation Collaborative, and known for numerous keynote presentations in the intersection between healthcare improvement, education, and simulation. I'd really like to start today's podcast with a quote, Victoria, something you said back in 2020, just before the pandemic hit us at the IMSH conference. And the quote goes, "Are we having an impact with our healthcare simulation that is truly translational? Because for us in healthcare, the idea of being translational has to relate to patient outcomes. Whether that is safety, whether that is effectiveness, whether that is equity or access, for us, the practical applications is why we are doing what we're doing." So could you speak to this notion of translational simulation, Victoria? What is it?
Look, I think, Michael, in any endeavour, we have to pay attention to our process, and I think we've been very good at that in simulation, and the community has uncovered and developed many ways of applying simulation as a technique. I think it's equally as important to have in mind what is our end goal. And again, I think there are many potential end goals for the application of simulation, and the ones I've been particularly interested in are those where we can demonstrate that patient outcome very directly. Now, this is not to say that an educational outcome isn't important. It is, and that can be part of patient safety, patient outcomes in other forms. But I think it's really important for us to, at various points, sit back and reflect and think, is the contribution I'm making measurable or visible as an impact at the service level, at the patient level, by whatever metric we want to do? And even more than that, if we kind of wind back a little bit, I was around as many in Laerdal were at the beginning of simulation, and I think we assumed that by training healthcare professionals that patient outcomes would be better. And my key point here is I don't think we can just make that assumption naturally. Yes, we need to develop healthcare professionals. Yes, we need to develop teams, but we also need to apply simulation to better systems and better ways that teams can interact with those systems and individuals can work within those systems. And I think that requires an additional layer of sophistication to our simulation techniques.
You bring up something really interesting here, where you introduce almost like layers, the individual person, the teams, and the systems. And you are among those who really advocate, it seems, to talk more about how it may impact systems. Could you say more about that?
Yes, well, I think anyone involved in healthcare knows that no matter how good our individuals are, or even how good our teams are, we ultimately fall or rise to the level of our systems. And unfortunately, and I can speak to this as a clinician, sometimes we feel a little bit helpless about trying to shape the system. We can feel a victim of the system. Whereas I think simulation I've experienced, if we can make it interwoven with our work and bring people together to explore their work as well as refine and improve their work, then I think what we start to see is clinicians and others involved in patient care being the agents of change for those systems and becoming re-empowered, as it were, to say, you know what, we can shape how we do our work, and it's really important to do that. And in fact, it's a responsibility for us to do that. So I've certainly found a lot of satisfaction in that myself. And as I said, I think we're seeing also an emergence of that systems work from many other fields of endeavour, including patient safety, which has definitely been reinventing itself over the last 10 or 15 years, and adding other approaches, such as the Safety 2 approaches, to the ways that we were familiar with 20 years ago of root cause analyses and so-called Safety 1 approaches.
Now you got me really intrigued. So what would this look like? I mean, in practical life, for trying to match this purpose, the why of simulation, with the tools and the methodologies. What would this look like in practical life?
Yeah, well, I'd love to talk you through a practical example that we are working on at the moment at the Gold Coast. And a group of clinicians has come to our team and said, we want to work on how we can safely and respectfully restrain mental health consumers who are suffering behavioural disturbance. And this is a very high-risk situation for staff. It's a high-risk situation for patients and consumers, families potentially. And to be honest, 90% of the time it goes really well, but when it goes badly, it often has big impacts. So the team come to me and say, do you think the simulation service can help? And I would say that 15 or 20 years ago, I would have said, yes, let's run some training programs and let's bring some of your more junior members to the training and we'll teach them how to handle these code black situations. Now, that is still good work to do, but I think now I have an additional tool where I say, I think what we should do is explore the practice here. I think we should bring together all the members who are involved in that, whether it's our protective services teams, the nurses who are working in mental health, the critical care teams who come to the Code Blacks, and others who are involved in this episode of patient care. And yes, we'll run some simulations, but what we'll actually be doing in those simulations, we'll be being curious about why people do what they do, trying to understand what different people in those teams, what their roles are, and trying to look deeper even than the behaviours and think, what are the relationships between the people involved in this process? And as part of that exploration, really asking people, do you think there's good practice that we need to be expanding so it's as consistent as possible? And do you think there are deficiencies, and what do we want to do about them? And can we use simulation to perhaps iteratively explore some opportunities for that? And so I think it means that we go from merely thinking, oh, well, if we just educate everyone well, they'll come together perfectly, and instead really start to, in a synchronous way, explore the individual, team and system contributions to that performance. And we'll come up with improvements that are probably at all three of those levels.
Yeah, and I'm sitting here with a very interesting paper of yours. It's called Translational Simulation, not Where, but Why, a functional view of in situ simulation. And you sort of seem to almost like deconstruct in situ simulation again. Finally, when we arrive there, someone's deconstructing it. But in that paper, you say something very interesting where it's almost like you're postulating three areas: education, system probing or system checking, and then the intervention. And I'm particularly interested in the latter two, the system probing and the intervention. What would simulation look different in these two, and what would they look like?
I think perhaps some of the techniques look very similar, whether we're working with a simulated patient or whether we're working with a mannequin. We're clearly going to have participants who are there. But I think it's about positioning what is the conversation and what is the purpose for being there. And I think, as I said, if we're thinking about this purely as an educational tool, then clearly those participants are there as learners and they're there to absorb a good way of doing things. And then I think if we think about it as system probing, instead we're really thinking about the participants as all being Confederates. They're all playing themselves in this. They're not there to be told what better way of doing it or even to be assessed against a certain standard. They're there to reflect on their usual practice and think about the interactions of their practice with those of their colleagues and the system in which they're trying to do that. And one of the other authors that I'm always admiring, Mary Dixon Woods and her team at this institute, and they talk about actually shifting away from this logic of intervention and saying, oh, we've got something we want to change and then we'll measure it later. And instead saying we're context shaping, which means we're actually thinking about what is the surroundings in which we try and do that? What are the forms we use? What are the cognitive aids that we use? What are the telephone systems that we might use in order to get help or to move patients to another area for care? And these benefit hugely from frontline clinicians having the time and space and skilled facilitators to help them come up with better ways.
And at the same time, there's this big wave rolling over healthcare, I guess, which is healthcare quality improvement. And the methodologies there may be even borrowed from car industry, like lean and others. So what does the meeting point look like here when simulation meets healthcare quality improvement?
Yeah, and I don't know the answer to this yet, Michael, but I think about it quite a bit. And I have come very much from an educational background, and I find myself stepping into this world of quality improvement, which is part of, but not all there is to, improving quality in healthcare. And I make that distinction carefully because I realize that quality improvement as a discipline has developed many useful tools. It's developed a language. It's developed a field of scholarly practice. There is a community of practitioners there. And I am not as familiar with that group, but have started to understand them a little bit better. And I think the meeting point is where simulationists can learn from that and use those tools, but where also we make it clear to those involved in improving quality in healthcare that we have some techniques that can complement some of the ones that are commonly used in improving quality in healthcare. And I think where we start to see some of these amalgams is the very technical approach where we measure quantitative outcomes, and that has some benefits, versus ethnographic and cultural explorations, and that has some benefits. And I don't think any of these disciplines are superior. It's about thinking, how do we meld them for whatever is the particular challenge ahead of us? And I think that's where simulation providers need to be really, back to our initial point, thinking about what is it that I'm trying to achieve. And there's not much point in just telling people to change their behaviours if there's very fundamental cultural issues underneath that that mean they're never going to speak up because that's not the norm in this context.
Yeah, and maybe even accepting that simulation cannot be everything in this domain. I mean, it may be about where the CT room is placed or the other processes. So, because that's an interesting point, though. Coming with a set of tools, both methodologies and simulators and whatever comes with it, we all also could imagine that we come with the answers to a problem. And could you say something about potential fallacies and sort of coming with your simulation baggage to this big domain?
Oh, absolutely. And I think we've got to be very careful about what we can offer and what we can't offer. And I think simulation program directors and providers should also be in the business of saying no if we're asked to do something that we're not going to help with. And there are some fields of practice that, at least in the way we currently practice simulation, we may not be able to assist. But I guess even coming back to where I wrote that original paper in 2017, I think what I saw was people very much anchoring to the place of simulation and saying, oh, it's great because it's in situ. And what they meant was a whole amalgam of things, was that we had opportunistically able to get teams together more easily, that we could explore some of those latent safety threats that were involved in our environment, that we could work on teamwork. But I think people weren't clear because they were defining their simulation by their place rather than by their outcome measure. And I think the same thing about coming back to the intersection with quality improvement, myself included, and a lot of my colleagues, we embraced this in situ simulation, and we'd run these sims and we'd say, great, here's a list of 150 latent safety threats that we discovered and someone should fix them. And I don't know that that's helpful either. And nor did we have many of the tools that quality improvement has developed in terms of how to identify risks, how to categorize them, how to set up a matrix of their likelihood and their severity of latent safety threats. And I think we still have much to learn about how we can draw on those tools to both document and enable next steps from the initial exploratory simulations.
This is a podcast from Laerdal Medical.
And I've been particularly impressed by some of those quality improvement initiatives where they've used measures very, very tactically and strategically, measure over time, set their goals, and try to reach for those goals. And that's why I think, could you reflect a little bit on the time and place for use of data and assessments in this intersection? Because I guess simulations, or many places, simulation is mostly used for reflection practice or try to reflect on your own practice. But what you seem to be advocating is that there may be a time or a place for using data more actively in this domain.
Yes, and once again, I think it comes back to what are you trying to achieve? One of the good targets for this kind of work are time-based targets. How fast can you get to the operating theatre? How fast can you get the stroke patient to the interventional radiology suite? How quickly can you get to the CT scan? And there's no doubt that if that is your target and that is what you are measuring, there's a whole range of simulation-based modalities and you will achieve that. I think what we probably need to be careful about when we use that data is that we're not doing what the quality improvement people would call resulting in unintended consequences, or not measuring the so-called balancing measures that we may be neglecting, for instance, the trauma patients if we're all focused on the cardiac patients or the stroke patients. So I think those sort of programs that are very narrowly focused are excellent, and I think data improves those, but that's what they should be seen as targeting a very specific patient outcome. I think equally it might be quite good to work, as we did recently, on a much broader topic like postpartum hemorrhage in the labour and delivery area, where we were really focusing more on what is the culture, relationships and practices of the intersecting groups in that field. And so we didn't have a really narrow measure of what is the transfusion requirements in PPH. We were looking to do something more regular that would probably shape the context and the relationships of the groups. And so as such, we weren't rigorously trying to measure every drop of blood that got administered via transfusion to women having a PPH, because that wasn't our only outcome measure. We were looking more broadly and probably acting more broadly. And this is quite hard to do because, of course, we know that many of the people that give us money within healthcare institutions, they love seeing a number at the end of these projects. But I think it's important to also be working on some of the fundamental underpinnings of performance, not just the very obvious behaviours that lead to them.
We've seen over time that simulation has become almost like its own thing. We see how the simulationists call the clinicians over, come and train with us. But is truly the healthcare quality improvement movement, is that where we could sort of really get on the same page, get on the same side of things? Same side of the sort of equation, so to speak, because I'm still wondering what this looks like for those who are skeptical to simulation, don't have time. I'm a clinician. I need to spend all my time in the theater. I don't see the value. No one's proven the value. So where do you see this go?
Well, if anything, I feel like these techniques that may be applied in situ or with translational impact sometimes are easier for those with less time or less engagement to start to engage with. And in part that's because it becomes physically closer to where people are doing their work. And if your simulation is literally a short, sharp, team-based mental rehearsal at the start of an operating theatre list, then you might only be taking up 10 minutes of those clinicians' time. And it may be very visible that the introduction's done and the mental rehearsal done has an outcome, that list, in terms of knowing people's names and being able to work together better as a team. So I think, for me at least, and I think some of my colleagues in this area as well, this has actually meant we're doing simulations and team training that is more flexible in format, that may be shorter, that may be closer to where clinicians work, and has the benefit of getting native teams together. Because, of course, as you say, when we went over to the simulation centre, often the doctors and nurses got to do that, but the porterage staff, the medical imaging staff, all the others who are really important, the admin staff in the team, they didn't go over to the sim centre, and yet often they are the very tacit elements of performance of a team that we also need to explore, work on, and hear explicitly about the contributions that they make to that performance.
So, Victoria, one more question following up on what you said on assessment, and now I'm going to dial it back now to education. I know you're deeply involved in medical education, and we as a company have also supported a lot of nursing education around the world. And I know a lot of people are thinking about how could I potentially use simulation for assessment, formative or summatively, in a way that is productive and doesn't really sort of take out the safety that we're trying to create. Could you say something about your practice in this?
Thanks, Michael. That is a really good question. And I don't know the answer, but I've got a few thoughts. I think carefully is the answer, because it's very easy for learners to have an experience of being assessed in simulation that, of course, then leaks into simulation that is for another purpose, like exploring practice. And if people come to a simulation exercise aware of an evaluation element, they will engage with it differently to if they are coming and thinking this is going to be a great way for our team to get better and to be truly interested and exploring and curious. So as with most things, it's about being really clear to ourselves if we're doing assessment, and being really clear to our learners if that is what this simulation is for. You asked what that means for my practice. I do very little in the way of simulation for assessment, but I don't think that means that we can't discuss performance. And again, this comes down to what are we talking about? System performance, team performance, individual performance. So I think it is important because, of course, we're making judgments all the time about what we think are expected behaviours or expected performance. So to some extent, we're not going to get away with the idea of comparing people to what we think they should do. But how we have that conversation is important and needs to be nuanced. Now, of course, there's many appropriate uses of simulation within particularly undergraduate education where we do have a specific desired performance, and this is purely about assessment. And trying to make that distinction for learners is very difficult, but important for us to do, I believe. When it comes down to go a bit deeper into some med-ed lingo, I think one of the unfortunate realities is simulation gives us highly reliable assessment, which means we can standardize it and we're measuring the same thing all the time for the same people who are being examined. But it often loses something in validity. Sometimes we're not measuring the right thing. And if what we're doing is measuring, for instance, our ability to have a conversation with a plastic mannequin, I don't think that's a very good way to assess communication skills. So once again, it comes down to picking the right modality to optimize our validity, while at the same time making the most of what we want for assessment, which is a reliable assessment that means it's fair across the learners who are engaging with it. So I think, once again, like all these things, clear on what we're trying to do, trying to be explicit with our learners and not pretending we can assess some things that are complex performance in a highly reliable way. I'm not a fan of assessing trauma team leader performance through complicated simulations, because I think we can do that better through peer observation and direct feedback in the workplace.
So let's try a sort of a thought experiment here, because I also have a good friend over in the US who is sort of a forerunner in the world of simulation, Professor John Schaefer, and he always talked about, the value statements, demonstrating the value. And the thought experiment goes like this. So imagine your dean or your CEO at the hospital. If you were in their shoes, what kind of value statements from the simulation activities would you expect from Dr. Victoria Braswell?
Well, I am probably a little bit biased, but what I would hope those value statements were is that performance and improvement are really important parts of healthcare, and that they are things that will be better if we get together and talk about them, and if we can come together with ideas about how to improve. So I think the single value I would like to come across is that we can do our work better together through engaging with simulation. And in fact, that's the sort of tagline we tend to use with our simulation service. When people say, what do you do? We help our healthcare teams do their work better together.
Yeah, so I think what you're describing here is actually a chasm of some sort that has opened up, but maybe what you're describing is also a way to close it back down again and bring people together and say we're all clinicians, we're all here for the sake of doing good, and simulation can play that role. I know my good colleague here, Björn, is sort of tripping to get into the conversation. So please feel free, Björn, to chip in on this. But fascinating, Victoria, really.
And I'll just pick up on that just before Björn starts. And I think we've been one of the silver linings of this pandemic is it's brought this kind of simulation well and truly to the fore, where we've used simulation as a technique to test and iteratively improve our processes within healthcare. So if there are some benefits to what we've all had to endure in the last 2 years, I think the simulation community should stand fairly proudly at the contribution they've made to the staff performance, their welfare, and to the system improvements. And I hope we continue to use some of the skills that we've developed in that process going forward.
Yeah, well, I've been informed that for instance, while the hospitals started to try to prepare for the total catastrophe as it looked like at the time, from the pictures from northern Italy, especially, that they saw that everybody had to be trained. Everybody, including the people that cleans the floors, the people that makes the food, absolutely everybody. Of course, they had to be trained for different things, but they had to be trained. And here also they saw that simulation was one of the important tools which was used. Well, Victoria, I want to go a bit back to some other things that we talked about before we started here. You are actually a host yourself for your own podcast. The Simulcast. Is that how you say it? Simulcast? Yes? Yeah.
That is how you say it, absolutely.
Why did you start with a podcast?
Yeah, well, this is like all good things. You have great friends and you have a bit of an idea. So this started with my colleague Jesse Spur, who's an intensive care nurse. He and I were involved in the conference that included some social media and critical care themes, and we got to be great friends, and many of our colleagues in emergency medicine were starting podcasts and doing them very successfully, and we felt there was a bit of a gap between what we saw as some excellent work from the academics in the simulation field, between them and then the people who we worked with at hospitals who didn't have a community of practice, who didn't have time or energy to read simulation journals, who weren't involved in research themselves, but who were the people doing a lot of the work. And we thought, well, wouldn't it be great if we could put together a podcast that, again, tries to access these clever people in the academic world and translate some of those messages to those of us who are trying to enact this at the coalface of simulation. So that was the inspiration. And along the way, we've picked up other friends, Ben Simon and Jessica Stokes-Parish, and now the four of us between us produce an array of different kind of episodes, but one of our consistent ones is a journal club where we look at papers each month and talk about them and deconstruct them as what we think of as somewhat beginners maybe in some of the methodologies, but we feel like we're channeling our audience in that way. But we also do some special topic episodes with people who are doing interesting things in the field of simulation. And again, really just to sort of highlight that great work, give other people ideas, and hopefully generate some discussion. But for me, it's really been about such a fantastic journey with both the 3 colleagues who are co-producers, but also now the people who've been kind enough to listen and give us ideas and come on our podcast as guests. Yeah, they should go to simulationpodcast.com. That is our website. You can also find us on Spotify and wherever you get podcasts if you just search for Simulcast, Podbean, Apple Podcasts, all the usual places. Of course, we're also on Twitter at sim_podcast, and that is also on Instagram. But I think the safest place is go to the website because we do little write-ups of our episodes there as well.
Thank you very much, Victoria, for this very interesting session. It has really been inspiring for myself, and I think for you too, Michael.
Indeed. Thank you so much for joining us, Victoria. Stay safe.
Thank you. Well, it's been a pleasure. I'm looking forward to seeing who else and what else you've got coming up on the podcast. It's always great to have fellow podcasters in the field. So good luck for your endeavours as well. And thanks so much for the opportunity to talk to your listeners.
Thank you, Victoria.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.